to Dr. Yasser Sadek. He will present a case that will always fear of coronary obstruction, and he will show us a great chimney technique for TAVI.
Hello everyone, thank you for GIS committee for this kind of invitation. I talk about chimney technique in TAVR. Okay. As you all know, coronary obstruction during TAVR rare but life-threatening, and we have multiple risk factors for that, like low coronary height, small sinus, bulky leaflets, and severe calcification. Chimney technique, it's a bailout or preventive strategy. We have some anatomical consideration like coronary ostia height, sinus or valve diameter, leaflet length and orientation, and CT imaging before TAVR is crucial for planning. And as you can see here in this illustration, how to do it, guiding catheter, wiring the coronary, and stent, and if you inflated the stent, this will be chimney, and I will show you some cases. So chimney technique is an important tool, and it carries high procedural success. But we have some risks like stent thrombosis, deformation, difficulty of recross again, and requires lifelong dual antiplatelet therapy, requires careful imaging and planning, best used selectively in high-risk patients. Ongoing research will define long-term outcomes as we don't have this data yet. So it's a bailout, yes. This is one case of a frail female aged 84 years old. She had symptoms of severe aortic stenosis and diagnosed as severe aortic stenosis with normal ejection fraction. And you can see here, this is the data of CT, and it's a really small annulus. The aortic valve annulus area is only 250, and the height of the left main is only 9 millimeter, and the sinus valva is so shallow. So this is a small annulus with low-seated left main with shallow sinuses. And at that time, it's 2023, we haven't only multiple platforms, only one platforms. So we decided to go for this patient from the start with self-expandable valve, Evolute R26 with chimney setup. As you can see here, there is guiding wire in the LED and stent in the LED, and positioning of the valve, as you can see here. So now the valve is under-expanded. So what we did post dilatation, and take care, you have to do post dilatation first and then deploy stent. Otherwise, you have to do simultaneous ballooning for the stent and the valve. So we did here post dilatation, then we positioned the stent. As you can see here, the stent should be in the aorta, protruded in the aorta, away from the insertion of the leaflet of the valve, and this is the final result. And another case, this is 82 years old female. She did TAVI in 2023 with Evolute 29. 9 months later, was diagnosed with bacterial UTI that resolved after 1 week of IV antibiotics. But after 1 month, she had low-grade fever, dyspnea on minimal effort, and we did for her 3 TE, and she diagnosed as infective endocarditis on this valve only after 9 months. As you can see here, this is the vegetation. So medical treatment was started, and the symptoms of fever and fatigue started to disappear. However, dyspnea worsened 6 months later, and she diagnosed with severe transvalvular aortic regurgitation after 6 months from the infective endocarditis. Okay. So we did for her CT, and we plan to do for her valve in valve. As you can see here, this is Evolute 29, and we engaged the left main and wire in the LED and the stent. And we thought that the best way to treat this patient to put a short stent in a tall valve. As you can see here, this is my valve, 26 valve, I think, and we put it, this valve inflated, and we tested the left main. Everything is okay, the hemodynamics is okay, so no need for this stent to be inserted. So this is not a true chimney, but it's bailout in case of compromise of this left main, and this is the final result of this patient. As you can see here, the left main is okay without stenting. Last case, 80 years old lady, non-diabetic and COPD. She diagnosed as severe aortic stenosis, and this is her CT data. She had very low left main, 6.8 millimeter, but she had aneurysmal left main. Left main is 16 millimeter in the CT. So as you can see here, this is her coronary angiography, and we decided to cross the valve first, and after we cross the valve, as you can see here, I'm not happy with the position of the valve. So the chimney here, it's double safe. As you can see here, I'm stopped here to engage the left main, and after engagement the left main, I found this safari wire in the circumflex. It's very near from the left main, so take deep breaths, and I repositioned the wire again, and inflated the balloon, and this is medium valve, I think, for accurate neo, and this is the final release. And no need for the stent for the left main. We engaged easily the coronaries, and as you can see here, the left main is okay, and it was an easy coronary access after that. So my conclusion that the chimney technique is a critical coronary protection strategy in high-risk TAVR cases. Chimney stenting appears to be an acceptable bailout technique for coronary obstruction with higher event rates among those with established coronary artery obstruction and among those without upfront coronary protection. Careful pre-procedure planning like CT assessment and heart team discussion is crucial. Be aware of long-term consideration like stent patency, coronary reaccess, and antiplatelet therapy. Innovations like Basilica, dedicated leaflet modification devices, and the next generation valve designs, I think, will reduce the need for chimney in the future. In my view, the chimney is best reserved as a bailout life-saving option, not as a routine strategy. Thank you.
One question. Well, Ziad sets up his side. Thank you, Yasser, very much. I think you missed with the conclusion, not putting your stiff wire in the circumflex, but no, it's the first time. It's interesting. Now, two questions. One, would you routinely use a guide extension catheter, especially when you're using a chimney in a valve-in-valve situation where your stent can get sort of obstructed between two metallic platforms? The second thing, would you please tell me how high do you go with the chimney? What is the single most important parameter do you want to achieve with the height of the stent you put?
It depends on the platform. The second one is it depends on the platform. If you use long stent, I think your stent should be protruded in the aorta above the insertion of the leaflet of the long stent. So it will protrude like 8 or 9 millimeter, and you have to secure that the flow is going without any constraint on the stent from the valve. So post dilatation is mandatory, I think, for this stent. So don't lose your wire except you do inflation or what's called post dilatation of this stent. This is first. Second, I prepare the guide extension, and if there is any difficulty to recross the stent, if there is any obstruction with the valve or something like that, I usually use the guide extension. If not, and the stent is going easily, I can. I remember in one case, I can't retrieve the stent without the guide extension. So I inserted the guide extension and I got the stent out.
So,
So go ahead, then, Dr.
Dr. Yasser, for the chimney, would you recommend any kind, special kind of stents? Because we know that we are dealing with metal and the radial force would make a big difference here.
Yeah, this is a good one. I think all the stent with stronger radial force will be preferable. Like Zines or stents of Boston, I think it will be better not a low radial force to avoid stent thrombosis and stent deformity in the future.
Megatron would be your best,
Yeah.
in all honesty.
Dr. Faisal.
Thank you for the great session. The basilica procedure, again, this is a question to Dr. Ahmed. The data is clear that even for patients who did not have basilica, who had a very high risk adenectomy, not all of them had left vein obstruction, and we used to get away with it. I think the future for us is actually to define strong predictor toward the investment in the basilica procedure. And the most important part that I do and I don't like about the basilica, it gives us the reassurance, but the laceration we create in the leaflet is not enough to ensure that this laceration is going to land exactly in front of the left vein. And I think the future is not necessarily for only the shortcut device, but for a device that take a huge bite of the leaflet to ensure a very nice circle across the orifice. Thank
This is absolutely correct. These are all very, very much valid concerns, and not to mention that the procedure is not as reproducible and simple as it should be, in all honesty. But
And
very
if I
good
may
points.
comment on this, I will show in my presentation the shortcut that you're referring to and the splitter which takes a bite out. So this is all really in the design, not even in first in human, but I'll show it when we come to it. That's a good point.